Before we get started, just a plug for guys like me in the trenches. 85% to 90% of cancer care in the United States is still done in community setting, not the major medical centers. Although practitioners like myself work very closely with the experts. I collaborate with Steve, I collaborate with Richard, and with Jerry very closely on a number of patients. We still do a lot of our work in the trenches, so the team approach, clearly important. We're part of the team too, so don't feel like you have to go and travel every minute to these places. There's a lot of cancer care and neuroendocrine care done in the community setting. Just pick your doctors carefully. And the last thing I want to make, if you find a doctor that knows everything, run as fast as you can. Who says he knows everything, you run as fast as you can away from him. Okay. First, couple of questions have to do with surgery, so we're going to go right back to our two surgeons. And they really relate to whether or not debulking surgery increases metastases because of microscopic tumor cell release into the bloodstream, or I'll add it, or tracking. Does that occur? And was that not the fear of debulking surgeries in the past?
Well, I'll take a quick stab at that. And so that is a myth, and we might as well bust that myth right now. It was originally thought in colon cancer. In fact, when I was training, we were beginning part of my training, there was still this concept of what was called a no-touch technique. That was that you didn't touch the primary tumor while you were trying to resect it. In fact, some guys would tie off the colon on either side of the tumor. And that was really because at the time we didn't understand cancer biology as well as we can now. Not every cell in the tumor is capable of metastasis. It's a clonal thing. Only certain cells are able to metastasize. And so physical disruption of cells getting into the bloodstream during surgical resection does not lead to an increased risk of metastasis, nor does opening a patient to look at what's going on and then closing lead to metastasis and bad outcome. These are myths, and we might as well be surgical myth busters today. Eric, anything to add?
Great show. This was on. So yeah, I totally agree with Steve. And there are a couple things. One thing is usually when these things are metastatic, the horse is out of the barn. Okay, it happens very early because these are very late to diagnosis. The second thing is usually there's stuff there, you just can't see it. So let me just tell you about some of the research we've done. So if you go into a liver, right, so I like to take out livers, and what you do is if you cut into places that are not normally associated with the tumor, guess what? There are a bunch of little things inside there, okay? So we do a lot of these things called gallium scans, and Odo will tell you more about that. So we had a bunch of patients came to us who said, oh, there's no evidence of disease. And then we did a gallium scan, and guess what? There's evidence of disease, right? So that stuff is going to be there, right? The recurrence rate in most of these studies was approaching 100%. But it didn't mean that the patient didn't do better, right? The whole philosophy is kind of like, well, yes, we know things are going to happen, but if we can kind of set the clock back, that still buys the patient many, many, many years of good quality of life. So that's kind of how we approach it philosophically. Yeah. And data-driven.
Yeah. Okay. If I could I just make just one comment to both Dr. Labudi and Dr. Liu? You know, the only time I've ever heard, and Kaplan was the first to suggest this, a gastroenterologist from London in 1997. But if you look at the system, the vascular system of the midguts and the pancreas, they're both, the blood supply leaves the tumor and goes straight to feed the liver. So I think we at least have to, like Eric says, the horse is out of the barn, because I think I don't know if you agree, but it seems to me that over that period of time, some of the clone cells can go straight into the liver because of the portal system.
Let's go on to the next one.
And that's probably how it goes.
This is another surgical question, and it pertains to two real questions here. One, if there was already liver metastasis, and this would be PNETs or carcinoid, so let's address them both. Does it make sense to remove the primary as well as the liver metastasis if possible? The next corollary to that If there's a single metastatic lesion to the liver, should it always be removed if accessible? And the second corollary to that is how many times can you do liver resections on patients?
Yeah, sure. So I'll tell you how I feel about it. So again, it depends on the risk and the benefit, okay? So if someone has, let's say, metastatic pancreatic, okay, then you have to say, well, what is the patient going to have a problem with, okay? Are they hormonal, okay? If it's a very hormonally active tumor, well, then, maybe a debulking operation would help them significantly, okay? Then the other question is the lesion so big that's causing mechanical problems? Well, then you should probably take those things out. What if the tumor is like 2 or 3 centimeters small and a bunch of liver mets? Well, then maybe you want to weigh the risk and benefit of the operation, right? Because there are real risks to the operation. What about your small bowel? Your small bowel, yes, take that thing out, because if you're going to be in there debulking, you might as well take it out because the risk is low, okay, right? So you're getting this sensation of the weighing of the two. So yes, so the answer is even if there's one, okay, I like to take them out. Now, again, it depends on how they behave, right? If there's one and there's only been one for a long time and it's the only one that's growing, you can take out laparoscopically a lot of time, and it works out really quite well. I've taken, onesie, twosie things out. The guy goes home in 3 days. 3 days, right? I did another one. A lady had a pancreatic tumor. She had one solid tumor that was growing on gallium, and I did her, and she went home in, a day and a half, right? So, it all depends on the safety profile of the thing. Because what will happen is there are different biologies, as Dr. Labudi said, and so some of these tumors will be solitary and will just grow. And they will grow, and they will grow, and they'll turn into 8 centimeter masses eventually. So why wait till it's 8 centimeters? You have to do a gigantic operation when I can do it when it's 2 centimeters and it's relatively safe.
Next question is a medical question for Dr. Warner, and anybody else who wants to butt in. Okay. First question is, what medications have been shown the best results at stabilizing or reducing tumor size?
As we said before, each tumor is different. They're not all the same. There is no one medicine that is the best. Otherwise, it would be the standard of care, and there is no standard of care. We have been doing in recent years molecular profiling of the tumors. That is a variety of tests of which chromosomal analysis has been involved. These tests are done on the specimen obtained at biopsy, and can help to determine the drugs to which the tumor any specific tumor might be best responsive. And this is the best way at the present time, besides just relying on experience, this is the best way, in my opinion now, of telling what's going to be the best drug for any given tumor.
Richard? Yeah, Richard. Actually, Tom, let me just go on because you'll answer the next one as well. So this is both for Richard and Tom. What tests to find tumors for those with markers and syndrome, but a negative Octria scan? So what other tests would you use for those patients, and what percentage of metastases are Octria scan negative?
So I can start with the advantage, and Eric will also give his comments, and we'll see this afternoon, we've now done almost 100 gallium 68 DOTA modified octreotide PET scans, and our accuracy for known METs in finding the primary is still holding at about 85%. So that's the most, to me, the most sensitive, non-invasive way to pick the primary up when you have known METs. On the flip side, you may have and I've learned again today, you may have every symptom and even biomarkers such as high serotonin. Dr. Warner mentioned chromogranin A. I've seen this with classic symptoms, and we've done 35 of those folks in a straight prospective way and have not been able to find them. Now, whether they're true negatives or a false negative, we don't know. We'll have to continue to follow. But if you have a known MET in your liver or a known MET by biopsy, the accuracy is approximately 85% in holding, and I'd like to hear Eric's comment on that.
Yeah, no, I would agree with that. The problem is it kind of depends on the tumor. So in our hands, we've looked at it, even like our small bowels, for example, right? So I told you location's really important, and here's an example. In our small bowels, about 83% of our patients, so it's very similar to what Dr. Odorizio said, have expressed the somatostatin receptor number 2. It's the one that we are so very interested in. But it changes. So like some of our lung carcinoids, their receptor status is lower. And so it really depends on the type of tumor you're dealing with. And sometimes you have high-grade tumors, which traditionally are thought of as not having receptor, and then they have very powerful amounts of receptor. So it's very different. I mean, really, if you've seen one neuroendocrine tumor, you've seen one neuroendocrine tumor. And so you have to think about each one individually.
Regarding the question of markers, I've found that pancreastatin is perhaps the most sensitive of the markers. Recently done a study in which we had 96 patients with biopsy-proven carcinoid, and they all had chromogranin A testing, and there were about, if I can recall correctly, 9 cases who were negative on chromogranin A, but were positive on the pancreastatin. They had abnormal pancreastatins. So in this group, not a single case with proven tumor by biopsy was negative on pancreastatin, whereas a number of them were on the chromogranin A. So it is, in my judgment, one of the best tests to use when you don't get a definite positive on the others.
Yeah, just to follow up on that, that's absolutely right. Chromogranin is a big earth person pro-hormone. It has no biologic activity as chromogranin A. It's when it breaks down, it splits and becomes pancreastatin or one of the other 2 peptides. It's 100 times more sensitive than the chromogranin A. And it's measured in a picogram amount, so that what Dr. Werner says is precisely right. Your chromogranin, I'm pleased to hear that, because chromogranin A may be normal up to 93 nanograms depending on your assay, but pancreastatin is an absolute value in a certain respect, in that the upper limit really is about 135 picograms. And so that's absolutely correct. But just remember, pancreastatin is 100-fold more sensitive by weight, and so that's why it's so precise.
It also helps with people on PPIs, too.
It does. It separates PPI folks from tumors, because chromogranin A will be high, gastrin will be high with PPI use, but pancreastatin will invariably be normal. And Dr. Woldering reported 3 or 4 exceptions to that, went back and looked at that, and knows that it really holds. Pancreastatin stays normal if it's all about the PPI, whereas in tumors, it's high.
Okay. I'm going to answer the next question very quickly, because they're basically yes or no questions. Can all carcinoid marker tests, blood and urine, be normal or within range and microtumors still exist? Yes. What is the best testing or scanning technique for detecting very small neuroendocrine tumors? And the answer is there is no best test. We use a constellation of tests, markers, scans, endoscopies, other procedures, radiologic procedures. So there is no one best test. Now, in the interest of time, most of the remaining questions have to do in one way or another with how we follow patients and what we do for sequential monitoring. So I'm going to ask each one of our doctors to answer a number of these questions at once, and they can go down the line, because we're going to get different answers, I think, from the different panel members. The questions are, what are we recommending to our patients as far as diet and exercise? What are we recommending for our patients as far as intervals in follow-ups for tumor markers and scans? And what are we recommending for our patients as follow-ups for potential surgeries, redoing resections or or interventional therapies. I'm going to start with you, Tom.
So, let's see. In general, what we do at University of Iowa with Jim Howe, our endocrine surgeon, we, following the first surgery for, let's say, the midgut, the carcinoid tumor, we follow every 6 months with CT scans, which we consider and must be considered still the gold standard for follow, because nothing happens, I think, at the present time unless the CT scans change. We, however, do the panel of biomarkers, and biomarkers will precede by weeks the CT scan change. And we will base sandostatin regulation or adjustment of sandostatin based on a jump in serotonin or pancreastatin. So we use the markers to anticipate that there'll be a change, and we do that. Regarding further surgery, Dr. Howe has completed a fourth lymph node reduction on a patient over a total of 6 years because the CT scans show recurrent nodal growth. And as Dr. Liu showed or suggested, you know, the lymph nodes can be a very big problem in the long term. And so Dr. Howe has gone back repeatedly for that. So that's how we do it. And we don't do the PET scan, gallium PET, at this time to follow recurrent disease. We use the CT-MR. For 2 years, every 6 months.
Tom, Arctria scans, how often do you do them?
So I do Arctria scans once. And if you go back to the original literature with Jean-Claude Roiby, who mapped all of the SST2 receptors for all the neuroendocrine tumors, he made one statement at the end of the whole period of time: once you're positive, you're always positive. The thing you want to know about from the Arctria scan is, do you light up? If you light up, you have a rationale for sandostatin forever, as far as I'm concerned. And the other comment that was made for static, and Dr. Gersten talked to that, octreotide is now accepted. It's not an indication, but it is anti-proliferative. And the PROMID study that he showed really shows that piece of work. He showed it beautifully. The control group got saline for 6 years. The group that got 30 milligrams of Sando for 6 years in Germany, 5 centers, went for a 17-month time to progression, and if they had very low liver tumor burden, they went to 24 months. And so that showed for the first time against the placebo that it is anti-proliferative. We all know it's indicated for symptoms, but it's convincing yourself that even though you don't have symptoms and you're showing tumor, you probably should be on it.
Jerry, you want to comment on your slant on this? When
Yeah, I
we
look
at the heart?
I look at it from the standpoint of the heart, so I'm just going to give the additions, and that is, with respect to diet, recent studies have shown that 2 diets prolong survival. One is vegetarian and the other is Mediterranean, which is essentially a vegetarian diet plus fish and allows you to have a glass of wine with your meal. In addition, we look at the possibility of recommending niacin, omega-3 fatty acids, and aspirin, and there's a rationale, which I'll talk about later, for considering each of those. And in terms of monitoring, I follow markers along with the team, especially Dr. Warner. And in addition, I follow our patients with echocardiography because 50 to 70% of patients with carcinoid syndrome will at some point in the course of their disease have cardiac involvement.
So I have a question for you, Jerry. In a patient who is asymptomatic, do you recommend a baseline echocardiogram?
No question about it. Regardless of the presence or absence of symptoms, sometimes we cannot hear the murmurs of fibrotic and leaking valve. Sometimes the patient just doesn't have a cardiac symptom. Sometimes the signs of carcinoid syndrome and right heart involvement are very subtle. We get a baseline echo whenever the patient is referred to me.
And is a regular echo enough? Should we do a transesophageal?
In most instances, if you have an experienced echocardiographer, and our technician has essentially studied all of our patients, he will pick up with just a transthoracic echo, even a tiny amount of carcinoid involvement of the valves. And when you compare his echoes with those that are done by a person not experienced with carcinoid disease, there's a vast difference in the ability to pick up carcinoid effects.
In addition, a small percentage, somewhere between 3 and 5% of all carcinoids will have cardiac metastases. That is, the tumor can spread to the pericardium or the myocardium, the heart muscle, and this has nothing to do with the valvular scarring that occurs as a complication of carcinoid syndrome. So this is an additional reason for having imaging done of the heart, the echocardiogram.
Great. For our surgeons, I just want to, since we've talked about patients, how to follow patients with active or metastatic disease, for our surgeons, I'd like them to answer the same question, but for patients who have had resected disease and are considered clinically NED or no evidence of disease, how would they follow these patients?
So this, I think, is a key question, because I, as the rest of the folks on the panel, see patients every week that come in with logs of tumor markers that they are following and graphing very meticulously over time, and get very concerned when numbers bump up and down and what should I do and how should I change therapy. And my greatest piece of advice is to take the logs and throw them in the garbage, because there's no evidence that tracking any of these markers and then impacting on the marker in the absence of something that Dr. Odorisio said, which is very important, and this is something I want you to remember, in the absence of a finding on an anatomic imaging study, like a CT scan, there's no evidence that intervening on these little blips that happen in these markers is going to have any impact on your outcome. They're useful tools for us in clinical trials. They're useful tools for us as we try to sort through and find the best marker that hopefully someday we'll be able to say, if you follow this and it gets above this and we then do that, you're going to do better. But unfortunately, in April of 2013, we don't have that. And so anatomic imaging. So quickly, in the answer to what do I do and follow up for a patient who's had resection for either a primary or metastatic site, is I do follow markers, but mainly to guide me in terms of timing of anatomic imaging. As a general rule of thumb, for the first 2 years after surgery, I'll get anatomic imaging every 6 months, and then depending on that individual patient's biology and pace of disease, I'll extend it out to once a year, maybe once every 2 years if we're out beyond 5 years and they haven't manifested a recurrence. But anatomic imaging is what guides my decision-making in terms of a next intervention, whether it be systemic therapy or another surgery, not the measurement of a biomarker.
CT scans, MRs.
Yep.
I have to disagree in part. I agree with doing periodic, every 6 months, CT scans for the first 2 years out, and then yearly. I go along with that. But the discounting the value of markers, I disagree. It all depends, of course, what markers you use. But I'm sure that Tom Odorisio is going to agree with me, and others too, that very often markers will indicate progression of lesion well before you can see it on the imaging technique, so that it should heighten your suspicion to look or perhaps increase some treatment or other, particularly if symptoms are increasing. As far as the question of diet and exercise, exercise should be to whatever is comfortable, and there is no restriction on that. And in fact, people should not invalid themselves because they'll get atrophy from disuse. As far as diet, I agree with a very conservative type of low protein diet, but not necessarily otherwise. To eat. Yeah, the wine is okay.
No, just expensive wine, only expensive.
And hence,
But
the difference.
I don't espouse a diet where something is emphasized in particular. Like I saw a patient who had carrots and carrot juice every day, or things of that sort that have been put forward as being beneficial. The only thing that I think some of us might agree with is Dr. Waltering's feeling that black raspberry extract is helpful.
Yeah, okay, so hence the difference between our surgeons and our medical doctors and the team approach.
That's right. If I can answer one quick question. Someone asked about how many times can you operate on the liver. So that actually makes a difference because when you operate on the liver, you can actually operate on it several times. The problem is getting into the abdomen safely and carefully. So if you know that someone, like for example, is going to need multiple operations for their carcinoid, you want to prepare the belly for the next operation too. So, it's my job to think 4, 5, 6 years ahead to prepare for that. So you can do it as many times as you need, as long as you're thoughtful about it.
And Dr. Gerstein, just one comment. Sure. So the marker that really seems on both sides of the ocean seems to hold up to bode for overall survival for midgut is neurokinin A. The paper just came out in Pancreas last month, but it's been supported by the Northern Ireland paper. Neurokinin A, when it rises above an absolute value of 50, will bode for a shortened overall survival. No one knows why. The tumor can be out of the bowel, and it still is a trigger. It behooves you to start thinking about next options to bring it back into the normal range. Pancreastatin is the other. The only other thing I would suggest in terms of, I agree completely with exercise and even drinking before a meal, but the thing you need to do if you're symptomatic, because the 5 E's have never changed: exercise, emotion, excitability, ethanol, and decongestants all turn on carcinoid. It releases serotonin because it's adrenaline-driven, and the thing to do, 30 minutes before you do anything, you take a sub-Q injection of sandostatin, and you're protected for 2 hours. It works every single time. 18-year-old, went to college, became 21-year-old with his mother in the room, said to me, is there any way I can have a beer? I get blushing. And so I recommended the subcutaneous sandostatin form. First time in 5 years, she never sent me a Christmas card. Here. Okay.
The only thing I want to clarify, Tom, and I think you'll have to agree with this, is that there is no evidence yet, in the absence of imageable disease and a response on imageable disease, that giving therapy and seeing a reduction in a marker has any correlation with survival. So at that point, has to be clear that evidence does not yet exist.
I just want to add one comment, and that is that there is a correlation in our patients, especially after open heart surgery, of serotonin levels with recurrent disease on the newly implanted valves. And so we follow markers very closely, and I'll pick up the phone and call Dick Warner when I get the results of the markers indicating that they're not heading in the right direction.
2 last comments before we break for lunch. One question addressed the possible use of Avastin, which is bevacizumab, which is an EGFR antagonist. And this drug is not FDA approved for the use in carcinoid or carcinoid tumors or pancreatic neuroendocrine tumors. There is a study ongoing in Stanford which is looking to address it. There's anecdotal evidence, but there's nothing proven yet that this has any efficacy in it. There are some third-party payers that are approving it. I have used it, but to this date, it's not FDA approved for treatment or for maintenance. Another question addressed whether, what to do when a radiologist, when you're getting two different answers from a radiologist on tumor, size of tumor changes, and how to avoid this. And the answer is don't put up with it. Take your scans and have them read at a major center, a reference center, or bring them to Dr. Labuti's team or Dr. Warner's team or Dr. Lou's team, and have them read by all the scans, have them read by the same radiologist at a competent place, but don't put up with scans being read by different doctors and you're getting different results. That's just not acceptable. And the last question addressed given the rarity of NETs and the array of the type of NETs, should we have a bigger population database, and why can't we get that done, and is it a violation of HIPAA to do that? And the answer is it's not a violation of HIPAA to do that, but we've got it, and this is part of the new push for electronic records. Hopefully all of our electronic records will be able eventually to communicate with each other, even though they're different systems. They all have to be HL7 compliant, so hopefully they'll all be able to communicate with each other, and we're going to have a correct national database at some time.
In commentary regarding the database, we just completed a study at my institution of over 6,000 cases, some from our place and others from elsewhere, 6,600 and some cases with small bowel carcinoids. So we have the data, and it's been submitted for publication.
Thank you, and thank you all for indulging us. Have a good lunch.